Welcome back to the deep dive. If you've been tracking, well, any news in the last couple of years, you definitely know the names semaglutide and tirzepatide.
Oh, absolutely.
These drugs, these GLP-1 receptor agonists, have just dominated global health headlines, financial news, everything, mostly for obesity and type 2 diabetes.
Right.
But today, we are zooming way, way out. We're looking past that initial role to a wholesale paradigm shift happening in the pharmaceutical world.
That's right. The source material we have today, it really reveals we're in a pivotal moment, a major one.
How so?
These medicines, they aren't just metabolic treatments anymore. They're being officially recognized, and this is the key part, by the very companies that invented them, as foundational longevity therapeutics.
Foundational longevity therapeutics. That is the core mission of this deep dive, then, to unpack what this seismic shift actually means for the future of medicine. We're going to look at the surprising benefits that, popped up in long-term trials, explore the next generation of these drugs from oral pills to multi-agonists, and really understand why these molecules have become this brand new imperative for every major drug developer out there.
Okay, so to start, let's just make sure we've got the core mechanism down.
Good idea.
So GLP-1, it stands for glucagon-like peptide 1, and it's really a beautiful piece of natural engineering. It's a gut hormone released when you eat.
So it's the body's signal that food is here.
Think of it as the body's, okay, I'm satisfied and now I'm handling this signal, yeah.
Right, the incretin effect.
Right.
So what does that signal actually do?
Its main job is multifaceted. It boosts insulin secretion, but, and this is critical, only in a glucose-dependent way.
Meaning it won't cause your blood sugar to crash.
Exactly, no dangerous lows. At the same time, it dials down glucagon, which raises blood sugar, and crucially for weight loss, it slows down how fast your stomach empties.
And that slowing effect is a huge part of the satiety.
It is. That, plus its effects on the brain, is what makes you feel fuller, faster, and for much longer.
Okay, so that explains the metabolic home run. But this leap to a longevity therapeutic, that implies something much bigger, something systemic.
It does.
Let's trace that shift. The sources point to a very specific moment, a date and a place where this whole narrative officially flipped.
Yes. The 12th Aging Research and Drug Discovery Meeting, the ARDD meeting in Copenhagen, August 29, 2025.
What happened there?
That meeting was a real inflection point. The atmosphere was apparently electric because the day before, Dr. Andrew Adams from Eli Lilly, he posed this. Well, it was described as a career-defining seismic question.
And the question was?
He asked the whole research community, are GLP-1s the world's first longevity drug?
Wow. And the very next day, the answer came not from an academic, but from the heart of the industry itself.
Precisely. Dr. Lotte Bjerre-Knudsen. She's the chief scientific advisor at Novo Nordisk, the person who won the breakthrough prize for semaglutide. She cemented it. She actually updated her presentation slide.
What did it say?
The title was changed to, and this is unequivocal, semaglutide as a proven longevity medicine.
They're calling this the deep-seek moment for longevity biotech. Why does that pronouncement from Lilly and Novo Nordisk carry so much weight?
Because it signaled the official institutional embrace of the longevity field. I mean, for years, aging research was kind of fringe, right?
Right. It was all small biotech startups.
Exactly. But when the giants behind the biggest drugs on Earth declare their multi-billion-dollar molecules are foundational longevity therapeutics, everything changes overnight.
So having a GLP-1 molecule is no longer a niche asset.
It becomes a new pharmaceutical imperative. It's something every major company must have to even compete.
It's just fascinating how this long-term data is retroactively reshaping the mission. They went looking for glucose control and stumbled into something much bigger.
That is the key insight. These powerful pleiotropic actions, these systemic benefits, they were almost accidental discoveries. And what's truly fascinating is that many of these critical benefits are actually independent of weight loss.
And the biggest one, the one that really cemented this whole claim, was cardiovascular protection.
Absolutely. The evidence there is robust.
We're talking about massive trials, right? The SELECT trial, a whole host of others.
Yes, 8 distinct cardiovascular outcome trials in people with type 2 diabetes, plus the huge SELECT trial in people with obesity. And they all consistently showed a significant reduction in major adverse cardiovascular events.
So fewer non-fatal strokes, fewer heart attacks, lower rates of cardiovascular death.
Correct. But the timeline is the really dramatic part.
This is the part that gets counterintuitive.
It is. The cardioprotective effect was seen incredibly rapidly, within just a few months of starting the drug.
A few months.
Yes, and this happened before the patients had achieved any kind of meaningful weight loss.
So it's not just that losing weight is good for your heart?
It's not. The analyses confirmed it. The amount of weight a person lost didn't actually correlate with the size of the reduction in heart attacks and strokes. It points to a direct systemic effect.
And this isn't just about the heart. We're seeing benefits in other major organs critical for aging, like the kidneys and the liver.
Absolutely. In one trial with TTD patients, semaglutide cut the rate of kidney disease progression and cardiovascular death by about 24%. And it shows huge promise for MSH.
Which is that severe fatty liver disease that's becoming an epidemic.
Exactly.
But this raises a big mechanistic puzzle. How is it helping the kidney and the liver if the GLP-1 receptor isn't even really present on the main functional cells in those organs?
That is the big question. We know the receptors in the brain, the gut, and importantly, on immune cells, like T cells, and on vascular cells all over the body.
So the benefit in organs without the receptor suggests it's an indirect mechanism.
It has to be.
So is it possible that this is really a sophisticated anti-inflammatory drug that's just been masquerading as a metabolic one?
That's precisely the hypothesis that's gaining the most traction. The sources point to systemic inflammation as the unifying factor. GLP-1 signaling is known to acutely reduce inflammation body-wide, and that effect often requires signaling through neurons in the brain.
So this widespread anti-inflammatory action could be the real driver behind the heart, kidney, and liver benefits.
It could be. It's like a holistic, systemic tuning of the body's inflammatory baseline, totally independent of the pounds on the scale.
Okay, so if the injectables, semaglutide, tirzepatide, are the gold standard now, what are their limits? What is the industry spending billions trying to solve next?
Well, the biggest limit is the needle. They're complex peptides. You have to inject them or the stomach just digests them. So the future is all about oral small molecules.
Because they'd be cheaper, easier to store, easier to take.
Much cheaper. And critically, far easier to combine with other therapies. The race is on to create a best-in-class small molecule that you can take once a day, or, the holy grail, once a week.
A once-a-week pill would be a total game changer. But the road to an oral version has been littered with failure.
Oh, absolutely. The sources use two big examples to show this. First, Pfizer's danuglipron. That was a cautionary tale for the whole industry.
What went wrong there?
The drug worked, it showed good efficacy, but development was stopped completely because of just exceptionally high rates of GI side effects. We're talking severe nausea and vomiting.
So people just couldn't tolerate it.
They couldn't. Discontinuation rates were over 50%. And on top of that, there were some safety concerns, potential signs of drug-induced liver injury.
So they just couldn't clear that technical hurdle.
Couldn't clear it.
Okay, so you contrast that with Eli Lilly's orforglipron.
Right. Orforglipron is still in late-stage development because it's a big step forward. It's also a once-daily pill, and it definitely has GI side effects. That seems unavoidable. But its safety profile is significantly cleaner.
Especially on the liver signals.
Exactly. Lilly seems to have found a much more manageable balance between efficacy and tolerability.
So if orforglipron is the benchmark for once daily, what's the mission impossible goal that everyone is chasing?
A once-a-week oral small molecule with an exceptional safety profile.
And that's incredibly hard to design.
It's a huge challenge in chemistry. You had to balance absorption, half-life, receptor binding. It's a multi-parameter optimization problem perfectly suited for generative AI. That's why you see companies like in silico medicine tackling this.
Now, beyond the format of the drug, there's this other huge trend, multi-agonism, stacking different keys into the same molecular lock.
And tirzepatide was the first big winner there. It's a dual agonist.
Hitting GLP-1R and GIPR.
Right. And GIP is another powerful incretin hormone. That dual action is why tirzepatide consistently beats semaglutide on both blood sugar control and weight loss in those big SURMOUNT and SURPASS trials. It just set a new bar for efficacy.
And of course, the industry immediately went for the next level, the triple agonist, which is retatrutide.
Retatrutide. That targets GLP-1R, GIPR, and adds the glucagon receptor. Now, glucagon usually raises blood sugar, but hitting its receptor also seems to increase energy expenditure.
And the weight loss numbers are just staggering.
Unprecedented. We're seeing 25, even 35% weight loss in some people in the trials.
We're also seeing combinations of different biological pathways like CagriSema.
Right, that combines semaglutide with an amylin agonist. Amylin is another natural satiety hormone that works really well with GLP-1. You're hitting two different fullness pathways at the same time.
So the strategy is now all about stacking these targeted therapies.
It is. We're achieving outcomes that, we really couldn't have dreamed of just 5 years ago.
Okay, let's switch gears to the central nervous system. The GLK-1 receptor is all over the brain, so there's huge hope for neurological and psychiatric uses.
There is, but this is a really complex area with, frankly, some mixed and almost frustrating results so far.
For neurodegenerative disorders,
No.
especially.
Especially. For Parkinson's, trials with exenatide have been inconsistent. Some smaller trials looked positive, maybe a slowdown in motor decline, but then the big definitive phase 3 trials failed to show a statistically significant benefit.
And we're seeing a similar kind of confusing picture for Alzheimer's, right? There was that promising real-world data.
Yes, that created a lot of anticipation. It looked like T2D patients on these drugs had lower rates of cognitive decline. But the most recent definitive phase 3 trials, EVOKE and EVOKE Plus, with oral semaglutide, they delivered a pretty sobering result.
No statistically significant reduction in cognitive decline.
That's right, they did not.
So what's the disconnect? The drug is clearly doing something in the brain.
It is. The sources suggest the drug is having an effect, but it might be too small, and maybe it's just too late to really halt the disease's progression.
So there were changes in biomarkers.
Yes. They saw improvements in Alzheimer's-related biomarkers in the spinal fluid. So the mechanism is active, but it's not translating into a strong enough clinical benefit. Maybe the disease is too advanced, or the dose isn't right for the brain.
Okay, but where the evidence seems far more compelling, far more immediate, is in substance use disorders.
Absolutely. This is a potential public health game changer. We have consistent results from huge cohort studies in Denmark, Sweden, the U.S., all linking GLP-1 use to significantly reduced rates of disorder.
Reduced hospitalizations for alcohol use, less cannabinoid use.
Exactly. And it's not just big observational data. We're now seeing small, randomized trials that support this behavioral shift.
Like the one for alcohol use disorder.
That's right. It showed people drank fewer drinks per drinking day. And even in a controlled lab setting, they just reported ingesting less alcohol. It's a powerful effect.
And it works because GLP-1 signaling directly messes with the reward pathways in the brain.
It modulates dopamine availability. The potential for tackling addiction on a global scale is it's enormous.
Okay. As revolutionary as these drugs are, the sources also highlight some big optimization challenges, particularly patient variability and the safety of rapid extreme weight loss.
Variability is a huge one, maybe the biggest immediate hurdle. Real-world data show that almost 43% of participants failed to get a clinically meaningful reduction in both their blood sugar and their body weight.
And that's a huge number of non-responders.
It is, and right now we don't have good biomarkers to predict who will respond and who won't.
We also have to address the safety concerns that get amplified in the media, specifically around psychiatric events like suicidal ideation.
It's so important to look at the actual evidence here. Researchers looked at huge populations across the globe, Denmark, Sweden, the U.S., and they consistently found that GLP-1 use was associated with a similar, or in some cases even a lower risk for suicidal ideation compared to other treatments.
So the large-scale data just doesn't support those fears.
No, the real-world safety profiles look very robust on that front.
Okay, finally, the biggest optimization challenge, achieving healthy weight loss. Because when you lose this much weight this fast, you're not just losing fat.
You are losing a significant amount of lean mass, muscle.
How significant?
It can be 20 to 40% of the total weight lost. And with the newer, super powerful drugs like retatrutide, one study showed a 12.5% loss of total lean mass.
That is terrifying. Especially for an older patient, you're basically trading obesity for frailty.
You risk trading one disease for another. That's why developing a muscle-sparing agent is an absolute mandate now, not an option.
So the industry is pairing these drugs with other agents.
Yes, focusing heavily on combination therapy. They're developing and testing specialized muscle-sparing agents, drugs like bimagrumab or trevogrumab in combination with GLP-1s. The goal is to preserve muscle and ensure healthier, more sustainable outcomes.
So what does all this mean for you, the listener? We started this journey with drugs for metabolic control, and we've traced their transformation into foundational longevity therapeutics, driving R&D into pills, multi-agonism, even neuropsychiatric uses. It's a stunning pace of change.
It is a revolution. And I think the most provocative idea that comes out of all this is the future of therapeutic stack. Yes, if GLP-1s become this foundational base therapy for everyone, tackling metabolism, heart risk, inflammation, What happens when we start combining them with other targeted anti-aging drugs?
So you mean adding on things like NLRP3 inhibitors for inflammation or agents targeting amylin or activin?
Exactly. If GLP-1 is the base, and we stack multiple targeted drugs on top, how do we even measure the cumulative effect on your lifespan?
On your health span?
We'd have to rely on complex tools like aging clocks to see if it's working,
It suggests the future of medicine is less about treating one disease at a time.
and much more about comprehensive multi-drug anti-aging regimens, all built on this new foundational GLP-1 platform.